This is Andrew Kramer, Urology Associates, Cape Cod, showing you these penile implants in high definition. This gentleman, Anatomic challenges, I would say that's always the case. There's always going to be something. You're never going to have the average, straightforward, easy, no complications situation. Maybe you do, maybe 1 in 100 times, but most of the time, as in here, we're going to find something. Extraordinary amount of veins, and look at that. It's just a lot of potential for bleeding. You've got to be meticulous. And, for me, I like to manipulate the bleeders as you go rather than let it bleed and control them later, because you can't do your best work if you're working in a pool of blood. As you can see, it looks dry. People always think, oh, surgery, it must be all bloody. It doesn't have to be. It can be clean and dry, and you can see what you're doing. And, we've just circumvented all those bleeders, and the ones we can't avoid, we've cauterized. But it is going to be a challenge every step of the way in this case. But inside the corpora, unfortunately, not as much blood as you would like to have. But we're going to measure and dilate, maximize size, and stretch like you always do, while also maintaining this perfect, called hemostasis, control of bleeding. So we're going to open. We're going to dilate down. We're going to dilate up. It's not even dilating. It's just measuring. We don't need to dilate. The space is there. So antibiotic irrigation, that reservoir goes on the left side. Just takes 20 seconds to do a reservoir. It's not a hard step if done appropriately. So the reservoir is over there on the left side in the pelvis. We've got the cylinders ready. I'm going to put them in. Notice again, no bleeding. Even from the corpora there, where they're open, we still control the bleeding at all times. So cylinder left is in. We're going to go ahead and do cylinder right. And after the cylinder's in, I'm going to close these corporotomies and then test it. You're going to see all the steps. So that's down in position. And now we're going to take that suture, run it closed. And once it's closed, it's going to be clean and dry again, and then I'm going to do the test. But you got to take a stitch, and you got to have what's called a watertight closure here of that corporotomy. It's completely closed at this juncture, or we're closing it. The right is closed, left is about to be closed. So we're going to go ahead and tie it up, and then the pump and reservoir go together. We're going to go ahead and use what's called a crimper. We're going to crimp it together, and now we're really done. We're going to test it now. So it's all in position. We're pumping it up. Pump now works because it's hooked up to the reservoir. So we're going to go ahead and pump it up. Tips are up, mid glands or distal glands, as we say. And I'm going to just mold it with my hand as we pump it up. But that's a really good outcome. And it could have been so much more challenging if we didn't contend with all those bleeders in the beginning. As you saw, they can be worrisome. So I did some modeling as well for Peyronie's disease. He had some dorsal or upward curvature. We mold it down, but again, upward is not a bad curve to have. Pump is low, deep, and dependent. Put up with that hemostatic agent, the fibrillar, definitely in this case, and then we're going to close with multiple layers. So I'm going to use a deep stitch and then a superficial stitch into that dartos layer, irrigate with antibiotics, and close the skin with dissolvable stitches as always. This patient's going to be fine and really off to the races in a couple weeks. No bleeding, you see really no swelling or bruising. Hopefully he does fine through the whole post-operative course. Andrew Kramer, Urology Associates, Cape Cod. Thank you so much.